Okay, I am going to be talking about spinal angiolipomas in pregnancy. And this is based off of a case that came in, I guess, 2 weeks ago now. Gigi, she's a 30-year-old G1P1001. She had originally presented to Abington at 39 weeks for an elective induction of labor due to severe back pain. So a little bit on her back pain. She presented to the AD at 17 weeks with pretty severe back pain. She was then told to follow up with her OB. Over the next few months, her mobility worsened. She requested a walker for ambulation at 37 weeks. She also complained of numbness over both heels, and she was having significant spasms in both lower extremities. She didn't have any bowel or bladder incontinence. She did see ortho outpatient during her pregnancy. I'm not sure what week, but they recommended steroids and an MRI, which she decided to defer to after delivery. On exam, it was benign other than lower extremity. She had decreased hip flexion and knee extension, but more significantly, decreased dorsiflexion and plantar flexion, worse on the right than the left, but like 1 to 2 strength in both extremities. And so kind of first thinking about like back pain and pregnancy, we can go to even just like back pain in general. We can put it into different categories. We can think about mechanical, so just pregnancy related from uterus growing and kind of the muscle strain there, injury to spine, discs, fractures, muscle strains. You can look at degenerative diseases like osteoarthritis, compressive fractures, maybe not so much in pregnancy, inflammatory, oncologic, and then infectious. And then when we're thinking about back pain, we want to be aware of kind of red flags that make us think less like normal pregnancy related back pain and make us think of kind of other things. In her case, this severe or progressive neurologic deficit, kind of a little bit of a red flag that this isn't just like a normal pregnancy related back pain. So when she was at Abington and starting her induction, they got an MRI before doing any kind of anesthesia, and the MRI showed severe cord compression secondary to large extramedullary extradural collection, posterior extending from T3 to T8, most likely an extradural hematoma, but some extension into and some apparent expansion of several neural foramen, which would be somewhat atypical. Obviously, neurosurgical intervention is needed promptly. So after that MRI, she was transferred to Jefferson. She had a C-section and then was immediately flipped over and had a thoracic laminectomy and resection of her epidural tumor. The final pathology came back on it as an angiolipoma. She went to the neuro ICU after that surgery and then was discharged on post-op day 7 to McGee. And then she was actually discharged this last Monday from McGee after being there for 4 days. She was ambulating with assistance and progressing towards ambulation without assistance per their progress notes on discharge.
Something going on with her vertebra?
Those were noted to be like benign vascular. Yeah. I remember seeing that too.
Like, that's the thing that pops out to me immediately, and then I'm like, oh wait, and then also there's a sarcoma thing there.
They were read as vascular malformations that were less concerning than the compression in the epidural space. The mass.
So just looking at spinal angiolipomas, they're very rare, benign extradural tumors. Looking at a literature review from just like all spinal angiolipomas, not just in pregnancy, from 2020, there were only 200 cases identified from starting in the 1980s till then. So they make up 2 to 3% of all spinal epidural tumors and 0.04 to 1.2% of all spinal axis tumors. They commonly occur in the mid-thoracic spine, on the dorsolateral aspect of the cord, histologically made up of fat tissue and abnormal vasculature. They have peak occurrence in women during the 5th decade of life. Usually the symptoms will appear gradually because of that progressive compression, but they can arise rapidly if there's some kind of intratumor hemorrhage or thrombosis. And then most have very good prognosis following surgical resection. Looking specifically at the prevalence of spinal angiolipomas in pregnancy, I found a 2019 literature review of which there were only 15 cases reported among pregnant women. And I didn't find any other cases outside of those. Of those 15 cases for symptom onset, 2 began at the end of the second trimester. Most of them began during that third trimester, and then 3 presented postpartum. They all had lower limb weakness or numbness, and then 5 also presented with back pain, and all but 1 were posterior thoracic tumors.
More common in thoracic versus
Yeah, it's like most common in thoracic. Yep. It's like here, most common in thoracic. And so looking at kind of like their symptom onset and case progression of these 15 cases, it kind of could be grouped into like 4 categories. So those who presented with symptoms postpartum, symptoms and then improvement postpartum, and then later recurrence of symptoms eventually leading to surgery, whether a few months or many years after the first onset of symptoms. And that was like 5 of them. Those that had worsening of symptoms throughout pregnancy and postpartum leading to surgery in the postpartum period, that was 3 of the cases. Those who developed symptoms postpartum and then had surgery, 1 was described as a year later, and then the other 2, it was unclear of when they had surgery. And then 3 had surgical management during pregnancy. 2 of them were not clear on like what the outcomes of delivery were. 1 presented with symptoms at 8 months. It said they had immediate surgery, but unsure of if delivery was at that time or later. 1 presented with symptoms at 7 months and said they had surgery 1 month later, but again, didn't speak of delivery. And then 1 had symptoms at 31 weeks, had a laminectomy, and then said they had birth at full term. But again, it didn't clarify whether it was a C-section or vaginal birth at full term. But so then going into like the pathophysiology of spinal angiolipomas in pregnancy, most of it is thought to be hormone related. The estrogen of pregnancy prompts fat tissue proliferation of the tumor, as well as blood accumulation. This idea of the vascular steal phenomena is more related to those who present with kind of those rapid, abrupt onset. And it's thought of this dense vascular structure of the angiolipoma can cause blood accumulation within the tumor and reduce perfusion to the spinal cord, especially at those watershed areas from T5 to T9, where the tumors are most commonly located.
That was, I think, the reasoning behind why we did neuromonitoring during the case, for fear of infarct. Yeah.
Thinking about workup, a whole spine MRI is recommended. Even though like most common in the thoracic area, they want to make sure that you exclude the presence of any associated spinal lesions, so whole spine. These tumors are usually highly vascular, so they'll have high contrast. You can also use inversion recovery sequences to get
gadolinium or anything with these MRIs?
So I think it was that they would have preferred a contrasted CT as the first line, was something that neurosurgery wanted as additional workup. There was no contrast in her MRI. I don't know about MRI with contrast.
based on that. I'm not sure about MRI with contrast, but based on this, like the 15 cases.
They would have preferred the
They
CT
wanted the
with
CT
contrast,
with
and they didn't do
contrast.
that because of the pregnancy,
Well,
or?
they said it wouldn't have ultimately changed what they recommended at that point because she presented essentially with at a decision point of surgery, no surgery.
I can look on what this said with
When-
contrast or not.
When ortho saw her, the recommendation should have been a CT with contrast first.
So we talked about, was it beneficial to do this surgery now, right after a C-section under the same general anesthesia? Would it be more beneficial to have an interval period of time? And during that interval period of time, would it be beneficial to have additional workup to better categorize this lesion? Because she only had the MRI, that was it.
Gotcha.
And one study that they mentioned that they would have liked was a contrasted CT. And I think that was to see just uptake of contrast, to see if it looked highly vascular or not, was my understanding. And then they decided that because of the severity of her neurological symptoms, it wasn't ultimately going to change their recommendation, which was resection.
So it's like a dumb question, but it was like in her thoracic.
It was with
So
thoracic.
why is that causing lumbar spine issues?
I asked this as well, and it was a downstream effect was how they described it. That was like the best way for them to describe it to me.
And since you said that a lot of this is estrogen mediated, is there a chance that it would just decrease spontaneously after pregnancy?
That is what I'm gonna talk about next, yep. Yes, so MRI spine, they do say that you can do the inversion recovery, which you can see the fat hyperintensity suppression. Of note, if it's low fat to like vessel ratio, you may not get that, which I think also occurred in ours because they were reading it more as a hematoma versus angiolipoma. But workup and like treatment.
Oh, I'm sorry, one thing was that our radiologist here overread it, the images, and gave us a read intra-op, which was that they thought it was gonna be an angiolipoma. They were right.
Go them. Because the initial path reading was also hemangioma.
Yeah, and then
they switched it. So when you're looking at treatment, this like 15 case review, and then there are like recommendations for it, where if pregnant and there's asymptomatic or mild or moderate symptoms, they recommended conservative expectant management just with close neurological observation for that exact reason that a lot of them are slow growing and they have spontaneous regression after pregnancy. But they did note that in all of the cases, they then came back to like had recurrence of symptoms. If pregnant with severe myelopathy, they recommended urgent surgical removal, taking into consideration that vaginal delivery could worsen the myelopathy due to increased abdominal pressure and then the unpredictable length of labor. So they recommended C-section to be like considered if gestational age was adequate. And then just looking at general recommendations not in a pregnant population, they say that total resection is the treatment of choice. If that's completely an impossibility, weight loss can improve symptoms in 80% of cases, but it's just gonna be like an improvement in symptoms, not completely.
Was she overweight?
Was she overweight? No, she was not at all. And then it's also recommended for just like general population that because these tumors can be very hemorrhagic lesions, you can think about preoperative embolization.
Her blood loss was equivalent in her C-section and her tumor resection. Same exact blood loss in each portion, yes. This was a very bloody portion.
Yeah, those pictures, yeah, so bloody.
It was shocking.
But that's all I have to say.
You can write it up.
Yes.
Yes, we're going to.
Thanks.
Wonderful job, Maggie.
Thank you.
Okay, now
Question, Maggie, did you go to this neurosurgery? Did you watch it?
I did.
Sophie did.
I scrubbed it. It was great. I closed it too.
you closed her back.
Wonderful.
I closed her back. No. It was
Good
fun.
job.
That's part of MFM Fellow.
The team was extremely kind and were excited to have me there. I learned a lot. I think it's always beneficial to, have the opportunity to look at how different subspecialties do things, and that was great.
My question is, do you think, so like with that patient we presented on OBCC today, like her pregnancy, obviously with the leukemia, her pregnancy like made us diagnose that, so I think it like saved her life.
Okay.
Do you think like this patient's pregnancy, like, because like a lot of times like did they delay imaging, things like that because you're pregnant? Do you think it like hindered or like delayed her care at all, or do you think it didn't have an effect?
I think it delayed
Delayed
her care. Like, I think that she would have gotten the imaging, or like,
Sooner.
it was very much her saying like, I don't want to do this imaging during pregnancy. I don't know if they would have recommended, like she was having very severe symptoms, so I think they would have recommended surgical management. I don't know if it would have been like earlier in pregnancy or just waiting till after. But
And she wanted to delay imaging, even because like there's no radiation in MRI, so.
yeah,
she's
I think it was
never
like
gonna know.
not great counseling or like not well documented what her reasoning was, but she just wanted to delay steroids and MRI until after delivery. So
I think we need to be more conscious about any neurological symptoms, and these back pains are debilitating and incapacitating, because we had in the same week 2 neuro patients. I had another one when we were on call with Sophie. I saw a patient with a resident who had back pain. This patient is a nurse, husband is a doctor, and she has been complaining of back pain for a while. So we requested the MRI and I reviewed the results. She has a disc herniation on that MRI. So we just need to request more MRIs, I think. And
Yeah,
discuss with the patients the safety, because we're diagnosing more things.
So what would be kind of your threshold for ordering the MRI? Because I feel like we have a ton of patients who come in with like sciatic pain or
Neurological symptoms, definitely. So if a patient needs a walker, I think we need imaging.
Yeah, one of the common symptoms between all three, it was the one that Dr. Roman and I saw on call, and then the 2 that were admitted, including this patient, was that they were not able to walk into the hospital or transfer from their wheelchair to the bed, all of
So
them.
they lost independence of movement.
Yeah.
That neuro patient who had surgery at 24, 26 weeks, she was not even able to get out of bed. So when we have back pains that require opiates, more physical therapy, incapacitating, neurological symptoms, we need to consider imaging and push for an MRI in pregnancy.
They had all consistently complained of it as well, and 2 of them were seen in triage for the same thing over and over and over again. But luckily they got imaging sooner than this patient.
And unfortunately, the lady who had the surgery a few weeks ago, who's a lawyer, by the way, she said that she got dismissive comments from providers like, oh, I also had back pain in my pregnancy. Yeah, I know how you feel. And then she ended up bedridden.
I think it would have been interesting and also challenging if this had been diagnosed earlier in her pregnancy, and just how we would have managed that altogether. I'm not sure. Like if it was diagnosed, say, around 28 weeks.
yeah,
Like,
She's kind of lucky if it's.
yeah. It was lucky and unlucky. I think like it expedited her care, but she also had to deal with this her entire delivery of her pregnancy. And she worked in a nursing home, I want to say, and that really impacted her ability to do anything. So, I don't know.
And also, it's sometimes difficult to put a patient out of work without the proper diagnosis, or send them to physical therapy without appropriate diagnosis. What if we make things worse? So we need to do more imaging, I think.
I wish that she had seen PT. They might have recommended more strongly that she get imaging. I find that they do pretty thorough neuro exams during their work.
Okay, it's 10:50. What is next in the agenda? Are we ready for
The journal.
Journal Club?
So we're just gonna present the article that Dr. Brigella had sent out to us last week from JAMA. That's the Magenta trial. It's a prenatal intravenous magnesium at 30 to 34 weeks gestation, and neurodevelopmental outcomes in offspring. Certainly feel free to stop me as I'm going through it if you have questions or comments, so we can discuss actively. So just some introduction. I think we all know preterm birth remains kind of the leading cause of neonatal morbidity and mortality worldwide. Preterm infants have a much higher risk of developing cerebral palsy compared to infants born at term. There is no treatment for cerebral palsy other than like kind of supportive care, therapy, things like that. So primary prevention is important. And in previous studies, prenatal use of magnesium sulfates among individuals at risk for early preterm birth improves the chances of infants both surviving as well as surviving without cerebral palsy. And so kind of that last statement is based off of a couple previous RCTs. So first there was the Crowther et al. Study, which is the ActoMag. So 4 trial from Australia and New Zealand, which was published in 2003, which had 1,255 participants. Their inclusion criteria for that study was less than 30 weeks gestation and delivery within 24 hours. Their MAG dosing was 4 gram load and 1 gram per hour maintenance. And their primary outcome was CP or like neonatal or fetal death, which they didn't find a significant difference between the treatment group and the placebo group. Their one significant finding was at 2 years of age, children who had been exposed to magnesium intrapartum had substantial lower rate of gross motor dysfunction compared to those in the placebo group. In 2007, there was the PREMAG trial by Merit et al., which was 688 participants. Their inclusion criteria was pregnancies that were less than 33 weeks gestation at increased risk for preterm delivery, and their magnesium dosing was a 4 gram loading dose only. They also looked at CP as well as neonatal or fetal death, and they found kind of no difference between the treatment group or the placebo group. And then the BEAM trial by Rouse et al., which was 2,241 patients. Their inclusion criteria was pregnancies from 24 to 31 weeks gestation, so 31 and 6, at high risk for spontaneous birth. Their magnesium dosing was a 6 gram load and a 2 gram per hour maintenance. They also did not find a significant difference between the treatment group and the placebo group for their primary outcome, which was fetal or neonatal death or overall diagnosis of CP. In a secondary analysis, they did find a reduced risk of moderate to severe cerebral palsy in children exposed to magnesium in utero. But kind of the current recommendations came first from this meta-analysis that was published in 2009 by Doyle et al., which when combining these 3 studies, they found a reduced overall risk of cerebral palsy with a relative risk of 0.71, and then a reduced total occurrence of death or cerebral palsy with a relative risk of 0.85. So that's kind of where our current recommendations come from. Worldwide, there's kind of variation in practice guidelines. So from FIGO, they recommend intrapartum magnesium from viability to 30 weeks, and they say to consider it at 32 to 34 weeks. The dosing that FIGO recommends is 4 gram loading to 1 gram per hour maintenance, so based off of that initial Crowther study. In the United Kingdom, the National Institute for Health and Care Excellence recommends intrapartum magnesium from viability to 30 weeks, and they say consider it from 30 to 34 weeks. And they have the same 4 gram loading dose to 1 gram per hour for up to 24 hours. The World Health Organization recommends considering magnesium from viability to 32 weeks. They don't give a specific dosing, but they give 3 different dosing alternatives, which is the dosing that was from each of those 3 studies individually. And then here in the United States, ACOG recommends intrapartum magnesium from viability to 32 weeks, primarily based off of that Rouse et al. Study. They don't give a specific dosing recommendation. Both ACOG and SMFM in kind of their practice bulletins committee opinions on intrapartum mag dosing just say that if institutions are going to give intrapartum mag, they should develop very strict guidelines for the dosing and when to give it. And so this study sought to assess the effect of magnesium sulfate compared to placebo administered to pregnant individuals at risk of imminent preterm delivery within the next 24 hours between 30 to 34 weeks. They looked at kind of the health of the individual, so the pregnant individual, infants, and the children. And so the study population is done a multi-center randomized clinical trial looked at 24 different Australian and New Zealand maternity hospitals. Pregnant individuals at risk for preterm birth between 30 and 34 weeks were included, and they could have either a singleton or twin pregnancy, and birth was either planned or expected within 24 hours. They had to have no contraindications to magnesium sulfate, so that's additional contraindications: respiratory depression, hypotension, absent patellar reflexes, kidney failure, or myasthenia gravis. And patients were ineligible for participation in the study if they required MAG for preeclampsia seizure prophylaxis. Thinking of the methods, they use randomization via central telephone randomization. They use balanced and variable block sizes, and the randomization was performed by an investigator who was not involved in clinical care. The patients were stratified based off of hospital location, gestational age, so whether they were 30 to 31 weeks versus 32 to 33 weeks, and a number of fetuses, 1 or 2. And then the participants, staff, clinical investigators, and assessors of the children were blinded to treatment allocation. So the procedure, 4 grams of magnesium was given versus placebo, which was just isotonic sodium chloride, and it was administered one-time dose IV over 30 minutes. Participants and the children after delivery were cared for according to standard practice of each hospital. And the surviving children were assessed by pediatricians as close to 2 years corrected age as possible. They had a neurologic exam to diagnose cerebral palsy, and they diagnosed cerebral palsy with this definition of loss of motor function and abnormalities of muscle tone and power. And they also had a psychologic assessment. For some of the children who couldn't be assessed by a pediatrician, the caregivers were given a survey about the kind of the child well-being as well as child motor function to see if there was any additional CP cases that would be diagnosed based off of caregiver assessment. So their primary outcome was risk of death or cerebral palsy in children at 2 years corrected age. And their secondary outcome, they had 36 different secondary outcomes that assessed the health of the pregnant individual, the infant, and the child. And so for the infant, there was a composite outcome of intraventricular hemorrhage, neonatal encephalopathy, neonatal convulsions, patent ductus arteriosus requiring treatment, respiratory distress syndrome, which is defined as increasing respiratory distress requiring increased oxygen concentrations or need for ventilator support from the first 6 hours of life, with the chest radiograph showing generalized reticular granular pattern with or without air bronchogram. Severity of any respiratory disease, use of respiratory support, air leak requiring drainage, infection confirmed by culture within the first 48 hours of life, and then after 48 hours as well, and then body size at birth and at discharge home. For the children at 2 years corrected age, the secondary outcomes were the individual components of the primary outcome of death, so stillbirth, death of a live-born infant, cerebral palsy with severity classified as mild, moderate, or severe, any neurosensory disability, blindness, deafness, cognitive or language score that was below 1 standard deviation of the mean on this particular scale, death or major neurosensory disability, cognitive or language score less than 2 standard deviation below the mean, motor delay, cognitive, language, and motor scores on the child behavioral checklist that were greater than 2 standard deviations below the mean, and then generalized use of health services since birth, childhood respiratory morbidity, blood pressure, and hypertension. And then for the pregnant participants, they looked at serious adverse outcomes such as cardiovascular respiratory outcomes from the infusion of magnesium, and the serious outcomes were death of the pregnant individual, cardiac arrest or respiratory arrest. And then they looked at kind of more minor side effects of the infusion like nausea, vomiting, flushing. And then they looked at postpartum hemorrhage with a blood loss of greater than 500 milliliters, or major postpartum hemorrhage with a blood loss of greater than 1,500 milliliters, and then mode of birth. So lots of secondary outcomes. So their statistics, they estimated an instance of that primary outcome of CP diagnosis or death of 9.6%. And so based off of this, to detect a 4.2% difference between the treatment group and the placebo group, with a design effect of 1.2 for clustering of children and 5% loss to follow-up. They estimated that they needed 1,676 children or 638 each group with a power of 80% and a alpha of 0.05. And then the 2-year outcomes were adjusted for the sex of the child, socioeconomic status of the pregnant individual based off of their address zip code, and then the language spoken at home, because they said the language spoken at home can influence psychological test scores.
Spoiler, their incidence was way off.
Huh?
And spoiler, their incidence was
Yeah,
way off.
exactly. So just get into results. This was conducted from January 2012 to February 2018. They had 1,433 pregnant individuals who were randomized and enrolled, which resulted in 1,679 infants that were alive at entry. 729 were randomized to magnesium sulfate. That's not say placenta, that should say placebo. 704 randomized to placebo. There is no difference in baseline characteristics at randomization, which we're going to look at in a sec. And then 95% of participants received the allocated treatment in each group. So here is their table 1. Like I said, there's no difference between the two groups. The twin pregnancy rate was essentially the same. And then the reason for like being at risk for preterm birth was primarily preterm labor in both groups or PPROM. And then there's adverse like antenatal testing of the fetus as well.
I just want to point out that one of the reasons for preterm birth was preeclampsia.
I wasn't sure about that because they said that they were excluding.
Excluded, right? That was my question. I was going to bring that
I
up.
didn't really talk about those that kind of reason in the discussion or later on.
Do we know what the Australian New Zealand guidelines are on giving MAG for pre?
Yeah, I'll look at that.
They might not have given.
Like they may only do it for like blood pressure or something.
Yeah, or they might have been diagnosed with pre, or might have. Well, I guess this is delivered early because of pre. They might not have gotten the MAG until after delivery.
Yeah. But this is saying like the reason for
the delivery.
birth is preeclampsia, which if you're going to deliver for 34 weeks for preeclampsia, you presume it's severe preeclampsia.
Yeah, but then
Unless they have some like different guideline, like they deliver at 32 weeks. Yeah, that was.
Or they delivered and then started MAG.
Maybe they only got the 4 gram bolus before the delivery, so they were included.
Maybe, yeah. But it's a pretty significant amount. It's 10% about in each group. So going into their results more. So the primary outcome of CP or death was seen in 3.3% in the magnesium sulfate group and 2.7% in the placebo group. Their adjusted relative risk was non-significant with a p-value of 0.57. And looking at their secondary outcomes, there was no difference in any of the childhood outcomes that I had mentioned, like the 3 of them. But they did note that children who were exposed to magnesium were more likely to have an overall behavioral score that was abnormal, with a relative risk of 1.66. And the infant outcomes, the 2 primary ones that were significant were neonatal distress was less likely in the magnesium group with a relative risk of 0.85, and the chronic lung disease was less likely in this group as well. And they define, and then for the pregnancy outcomes, there was no difference in the serious adverse outcomes. So that was like cardiac arrest, respiratory arrest, or pregnant individual death. They did note a lower C-section rate in the magnesium group with a relative risk of 0.91, but then they said that there was no between group differences in indication for C-section. They looked at that secondarily. So they concluded that in this multi-center placebo-controlled RCT, there was no difference in death or cerebral palsy in children at 2 years corrected age. And this was in contrast to the one meta-analysis I highlighted earlier, as well as a couple others since then. And it was also in contrast to previous RCTs that have identified a benefit of magnesium sulfate in kind of earlier gestational ages less than 30 weeks. They said that this might be because there's like a differential mechanism of brain injury at earlier gestations versus after 30 weeks. Certainly the risk of intraventricular hemorrhage is much lower after 30 weeks versus before 30 weeks. And then they said that there was increased neuronal migration and oligodendrocyte maturation after 30 weeks and like with successive gestational aging that could decrease the risk of like CP overall. They did note that there was a significantly lower rate of neonatal respiratory distress and chronic lung disease with magnesium sulfate exposure, which needed further exploration. And this was in concordance with like previous studies that have shown a benefit in children who get magnesium for like asthma. And then there was no serious adverse side effect related to magnesium sulfate use, although many like the secondary, like minor things like nausea, flushing, things like that were higher in the magnesium group. Their limitations was that their primary outcome was much lower than expected, and so the sample size that they calculated lacked the power to detect like smaller but potentially important differences in the risk of death or CP. And then pediatric assessment was only available in 81% of infants. That number did increase to I think over 92% when they included like the caregiver assessment of like motor and neurologic function. And then I think like important for us is Australia and New Zealand are not representative of a like worldwide population. Certainly they have like a different patient demographic than we do. They both also have socialized medicine, so care is much more readily available compared to our patients who are often underinsured or uninsured. So that limits the generalizability to kind of our population. In response to this, an editorial was published in conjunction from Judith Marie Louise and Tara Marie Randis, who are I think both from WashU and St. Louis. And so just kind of getting into the editorial. They also kind of highlighted the limitations of the study. So one of the things that they brought up was that it was a one-time magnesium dose of 4 grams. Obviously in the very, very first kind of Crowther study, that was kind of the dosing that was used. But they highlighted that since then, several studies have showed kind of the benefits of like continued infusion of magnesium after that loading dose. They also talked about the sample size estimates where they had a predicted outcome of 9.6%, and then their actual rates were 3.3 and 2.7% in each group. And then previous studies have showed a much lower rate of CP, particularly a rate of CP in gestational ages like over 30 weeks. I think it was like 2% and then less than 1% in a couple of the studies that they had. In a couple of studies they highlighted. So yeah, so in a Finnish study, the rate of CP was 7% at 30 weeks and then less than 2% at 34 weeks. In the BEAM trial, the incidence of cerebral palsy was 1.2% in infants born between 30 and 31 weeks, and only 0.8% in those born between 32 and 33 weeks. So their predicted outcome rate was significantly higher than kind of all of the previously published literature, which obviously decreased the sample size they needed to detect that 4% difference, but also maybe kind of limited the study's use. They also recommended like needing to further explore the benefits of the pulmonary side effects in the study. And then they highlighted that there was no serious adverse effect of magnesium, although the behavioral findings in the children at 2 years of age were concerning. And those, there's kind of been like mixed literature kind of highlighting that behavioral finding in, I guess, other studies. But despite all of this, they said that this should limit, or they supported this study in saying that it should limit intrapartum magnesium use for neurologic protection in patients who are at risk to give birth after 30 weeks gestation. Yeah, sorry, not the previous slides. I think in thinking about future research, we obviously, I think what we can see from like the original studies was that none of the original studies showed a significant benefit individually, and when they're kind of combined together, the meta-analysis did show a benefit. So we should consider kind of revising existing literature with the meta-analysis. I wasn't sure. I'm not aware of like any studies just looking at kind of magnesium usage in 30 to 34 weeks. But yeah. So happy to discuss further with everyone. I don't think I'm like convinced either way to change our clinical practice based off of this one study.
I think
Yeah,
the most interesting outcome was the respiratory. So that was really unexpected, and where they showed a major benefit of it.
Yeah.
another thing is I don't think we should change because they did, even though it wasn't statistically significant in their subgroup of like 30 to 32 weeks, the patients that got magnesium, it was lower, it's 3.3% versus 5.2%, versus when it's later than the percentage, I think was more actually in the magnesium group. But the fact that there was less, CP death below 32 weeks, even though it's not statistically significant, I don't think we should change our recs now.
I think we can wait and see what other institutions are gonna do also.
Yeah.
Yeah, Rouse said that he, it was on this, this is all over Twitter, obviously. And he still is advocating for 30 to 32. I think, there's a couple issues as you think about beam trial, such a wide range, gestational age range, most benefit in the earlier gestational age. And then now you have a mean gestational age, and this Australian trial that was over, I think, wasn't the mean over 32 weeks? So gestational age really drives this, as you mentioned. So I think that's like the important thing.
I have an issue with one thing, which I hope Keely can help us answer at some point. Remagging. And this thing hurts me so much. So can we pull the evidence for the protective effects of remagging? Certainly there was a Cochrane review a few years ago. I don't know if there's an updated one that actually showed it was not protective. So, and I've seen it here, we do it 2 times, 3 times. And what really upsets me is in our patient populations, who really we have to expedite their delivery and everybody sits on them until they get their 12 hours mag. Where the baby gets septic, the placenta is like necrotizing chorioamnionitis. So this is really a serious issue. So I hope, Keely, because I know you have a magnet for magnesium, because you worked on the guideline. And I hope you can look about, benefits versus risks of remagging, basically. And, is there a stratification depending on the patient population too?
Did we look at that in the when we were thinking of
No.
But also, that's what Beam did, though. If 12 hours passed without administration, I think, right, then they restarted.
I understand, but you can see the Cochrane, which I think published just 2017, maybe, I forgot.
I can look, and I could even try to pull it up real quick, but when we kind of talked about that IPD meta-analysis, when we were talking about MAG, that's one of the things they did kind of break down. And I think a lot of people argue, and the data kind of leans that way, although not incredibly strongly, is like the real benefit is how close the magnesium was given to delivery. And so I think
I understand, but if I'm having an infected mom in front of me with the
well,
white blood cell
you never delay delivery for magnesium administration.
I understand, but then people are not going to allow me to give Pitocin either, right? So I think really this is a big issue. I've had 2 babies here who died with me, I think, because, remagging was like an issue. Preterm babies, ruptured membranes, infected.
Our guidelines very clearly state that should not be the case. So,
I think if we can, but it's not about us only, it's about, how we educate, the residents, the general OBGYN and, basically our entire team. I really think we need to do some education regarding this issue.
So sorry, my bad. It was 6 hours, not 12 before they
But I think we went through, we had a case and we went through a whole lot about the delaying and planning magnesium before recently. And Keely did a great job of reviewing all the evidence.
Yeah.
We changed that on the guidelines. It's not going to delay delivery.
Look at this, like, I didn't even know that was withheld if preeclampsia developed. Interesting.
How about if chorioamnionitis developed?
Well, I don't know if they were,
I think, I'm not sure if this is exactly like they didn't give magnesium, they just gave magnesium for seizure prophylaxis protocol, not that they didn't retreat for neuroprotection.
Because some of them was placebo bags.
It's not trial anymore now. We need magnesium for a standard of care. So a question for the author, but this is how I see it.
yeah. Choreo. I think it was.
But getting back to kind of that question of should we not be doing MAG after 30 weeks? I mean, if you look at the original studies, like the biggest benefit was, like where they showed benefit was the earlier gestational ages. And I think it's because you're getting there are low rates of CP and much lower rates of death the further along you get in gestational age. And if we are seeing a risk of behavioral issues in children given MAG and we're not seeing a benefit at those higher gestational ages, I think it is something worth considering whether we should be MAGing that 32-week plus, or the 30-week and beyond range.
I mean, like, I know here we have like a conversation with the patients about like whether or not we would give them like late preterm steroids. I think like the late preterm steroid rate here is like much lower than other places I've been. I don't think we had that same discussion about magnesium. I think that's more of like a we need to do this intervention as opposed to the steroids is like we don't.
Yeah, I think like once we get above that 30-week mark, I think it needs to start being a conversation of there's not as much benefit to the MAG and there may be this theoretical risk.
I think it's also hard because no studies have actually compared like dosing regimens or compared like MAG once versus remagging, like Dr. Alcatli was, discussing. And so, I feel like that makes it tough. And obviously this was 4 gram, we do 6, Beam was 6. It's kind of like our best ever. I think most people agree that's kind of like our best study. So I think that makes it tricky too.
They didn't look at timing from MAG to actual delivery, did they?
No, they didn't.
And also, like, remember, all these trials were negative. This is like, and then the meta-analysis was what was technically positive. So there's like the first, like, again, I mean, I wonder what would happen if we add this to when the next meta-analysis comes.
I mean, I think, like, I definitely believe the evidence for 28 and below that the MAG has benefit. And I think probably up to 30, like, I'll believe that. But once we start getting into those higher early gestational ages, is there a benefit? Or how many tens of thousands of patients do we need to treat in order to have one benefit?
And seriously, my big thing here is you'll have a patient, I'm really suspicious for abortion. I'm suspicious health. I'm suspicious severe preeclampsia, choreo. Ooh, the first important thing, let's make sure the MAG is on board. You know what I mean? Like for me, I understand, but MAG is not maybe the most important thing. Maybe it's on the top, but maybe it's number 2 for me. You know what I mean? So I think everybody thinks it's the MAG that is going to be saving this baby when really there's so many other factors that are involved. I'm talking about your critically ill preterms. I'm not talking about just, your other category of patients, So like someone who comes in labor 3 centimeters, nothing else is happening, So I'm talking about the critically ill. But I do find it here at Jefferson, we prioritize giving the magnesium sulfate over many other things.
Yeah, like if you hear the argument from Rouse is that the harm is, I guess, minimal compared to the potential for benefit, knowing that even, we have a wide gestational age range.
Mhm.
I wonder if MFMU will take over. Yeah, lots of discussions on Twitter.
I forget, does anyone know if any of the other studies showed a benefit from a respiratory standpoint?
So those that they mentioned.
I think they were all negative, but again,
I mean, that's just, the one thing that really struck me from the study was the respiratory benefits to the babies with MAG.
No, they did talk about it.
you guys want to hear about, I guess, since we have time until billing, which
Oh, can I just conclude with one genetic question mark and we can discuss next week?
Yeah.
So one of the sequential screens we're reviewing, which hopefully when Sophie you're with us on genetics and Kavisha, I'm gonna ask you to start reviewing these genetic results yourself. We just have a patient with very, very, very low Papa A,
How low?
0.03.
how low can you go?
So what do you think? What do you think Huda is thinking?
Like placental issues?
Hats.
What?
Hats. Rare autosomal trisomy.
That's
So this
amazing.
can be a trisomy 7, a trisomy 19, trisomy 22. So we're adding her on for today, this afternoon, with my office hours.